Okay, well, hello everyone, and welcome to this webinar on nutritional and therapeutic recommendations for chronic migraines. We're here with Vanessa Peacock, who has a wonderful wealth of experience that she'll be sharing with us today. She has a Bachelor of Science in Nutritional Medicine from Thames Valley University in London, England. She's got a Master's in Science and Physical Therapy from the University of Alberta. She's got 6 years of experience in private practice at a multidisciplinary clinic. I think you were specializing in chronic digestive illness and persistent pain, and then 5 years experience focusing on chronic pain, right, as a physical therapist. And then currently she's working on her PhD. And I think she's right now in Berlin, which is awesome. So she's doing it focusing on topics pertaining to chronic pain rehabilitation. And she brings over 7 years of experience in natural health products industry as a product specialist, both in the retail level and manufacturing level. And she's, has over a decade of experience as an instructor. She's even taught some of our courses here at IHN at the Vancouver campus, such as Nutrition Through the Lifespan, which is in our diploma program. And she also teaches the continuing education course, Therapeutic Nutrition and Supplementation in Practice. And today, in dealing with therapeutic recommendations for chronic migraines, is inspired by that course. So I'm sure we'll hear a bit more about it towards the end of it. And just kind of a schedule for today. Vanessa will take us through a lovely webinar for about an hour, which is recorded. The replay will be available on YouTube, and then afterwards we'll have a Q&A section, which will not be recorded, and that's only for the kind of live participants. And I'm looking forward to it. My name is Theodore, by the way. I am a marketing and kind of student support coordinator at IHN, working primarily at the North York campus. But everyone give I know we can't see each other, but a warm welcome to Vanessa Peacock. Yay, thanks, Vanessa.
Okay, thanks, Theodore, for that. And so we'll get started with the actual contents of the webinar. So as far as timing, we may finish everything in 1 hour, but if there's, we can go over, of course, a little bit for extra questions. So it was planned for us to be able to get through the question section as well. Go right ahead and type your questions throughout the session when they come up. If I'm going to answer them, very, very shortly in the process of doing the webinar, then I'll just mention that, so you don't have to hold it until right exactly at the end. But and then if we'll have more dedicated time for questions right at the end. Okay, so and the session is being recorded, so it will be available for viewing after the fact. So right now I'm just going to start sharing my screen, and okay. Ahead, and we will just start playing. So this is an excerpt from a short course that I do on nutrition and chronic pain, which is actually starting. It's going to be 2 weekends, starting on the 28th, 29th of May, and then the next one where we're going to go over all different types of chronic pain conditions, nutritional therapy, and just a background on how they work. So what we're going to look at today is, of course, we actually have to talk, since we're talking about headaches and pain, we actually have to talk about what pain is, because what we know about pain actually affects how we experience it to a significant degree. So we're going to go actually through the global background of pain in general, and then we're going to talk a little bit more about migraine specifically. So how do they fit into the picture of pain and chronic pain? What's the definition? Who's most likely to get them? What are the risk factors? What do people experience? How are they managed in the sort of the allopathic medical system? How are they assessed? And then how can we do something about them, in a holistic manner. So what's the holistic nutritional therapy? What are the supplements that are researched for being very helpful for migraines? And then what are some other holistic therapies that also are effective for them? So we will get straight to it. So I'm not sure if anybody here who has actually had a lot of direct education on what pain is, but that's where we're going to start with. And I like to show people it's only a short 5-minute video that actually summarizes it quite well and summarizes some of the main points that are then going to be relevant to actually treating headaches a little bit more directly. So I'm just going to play this video right now. And this is from the NOI group, which is a research group out of Australia, actually, that produced some of the best research and some of the best tools for dealing with persistent pain. So please enjoy this video. It's quite well done.
Once upon a time, all the lands were fraught with persistent pain. So widespread was this affliction that 1 in 4 people experienced it. The pain lasted for more than 3 months. It shadowed their daily lives, held them back from everyday activities, and the interventions they tried proved useless. Hey, pain, go away. We've tried it all, but still you stay. Moving less, taking pills, knives and needles, and still we're sore. We can't take no more, no more. But the pain remains like a loyal companion. The people's hopes faded, and they became resigned to living with the pain. Only now the pain was a beast. Then along came a group of researchers, of which I am one. Back off, big fella. I'm Professor Lorimer Mosley, and I'm a pain scientist. Pain scientists are starting to think differently about pain and its causes, and we're making exciting discoveries, like how the way you think about your pain can change the way it feels. Over the next few minutes, I'll help you to understand your pain. Understanding is important because it can change how much things hurt and how much your body can do, and it can help you to tame the beast. First, trust me about this. Pain is not an accurate measure of tissue health. Pain is a protector. By making unpleasant feelings, your brain changes your behaviour so you can avoid injury or your tissues can heal. Sometimes pain is not helpful, like phantom limb pain. You don't expect a missing limb to ache, but it does, and the pain is very real. So how do we explain this? Well, pain is a warning signal from your brain that depends on credible evidence to say your body needs protecting. Sometimes pain's too protective and you get unnecessary warning signals. Pain scientists now understand that there are many ways our nervous system ends up producing unnecessary warning signals. Take conditioning, for example. You think of Pavlov's dog. Every time food was offered, Pavlov rang a bell. Of course, the dog would salivate seeing the food. This went on for a while. Eventually, the dog was conditioned to salivate for the bell alone. And conditioning is just one of the ways your body learns pain. And the longer your nervous system produces pain, the better it gets at producing it. Your body learns pain. So what feeds this beast? Well, let's look at how pain works. In your body's tissues, there are specific neurons which normally only respond to harmful stimuli, whether mechanical, chemical, or thermal. When they are activated, they send a warning signal to your spinal cord, which can in turn send a signal to your brain. This activity in neurons is called nociception, and it's happening all the time, but only sometimes results in pain. Most of the time, the brain protects you with other things, like movement. Once the warning signal reaches the brain makes sense of it based on the information arriving and a vast amount of information already stored. If there's good reason to think protection is required, then your brain makes pain. One of our amazing discoveries is that you can have pain without any physical stimuli. Thoughts and places might activate the warning signals, and the pain feels exactly the same. But it's not just your brain. Your spinal cord also learns how to generate unnecessary warning signals. So how do you know when your nervous system is learning pain? You may notice your pain spreads or comes on without warning. Your body feels odd and it's hard to move properly. Your pain changes quickly with your mood, and small annoyances can set it off. Old injuries start to hurt again. You're more sensitive to stimuli, and the longer the pain goes on, the more all of this occurs. The old way we understood pain could not explain these things and left many sufferers feeling like no one believed it was real, or for it to hurt so badly, there must be a major tissue problem. But we now know how persistent pain happens. So how can you tame the beast? Pain is a very personal thing. There's no one-size-fits-all solution. And while you probably have well-thought-out coping strategies, it's time to take a new approach to dealing with and reducing your pain, one that focuses on retraining your pain system. This might mean testing yourself physically and moving more than you normally would. Being honest about your current attitudes and beliefs can also help, as can asking your health professional new questions.
How do I know if my pain system is being overprotective?
How do I retrain my pain system to be less protective?
How do I know if I'm safe to move?
So be brave and have hope, because it is possible to tame the beast. Visit our website for more information and questions to ask your health professional. Tame the beast.
Okay, so I hope everybody enjoyed that, and I know that's a very short overview for actually what's a huge topic, and we'll talk, of course, about how headaches fit into this specifically, because of course they mean every type of pain: low back pain, neck pain, shoulder pain, knee pain, everything. But headache pain does have its place in this role, because pain always means essentially the same thing, which is that it's an alarm reaction to a perceived threat. So it is unconscious is the other very big thing that needs to be emphasized. So people don't get to decide whether they're going to be in pain or not. So it happens automatically. But what we think about pain, what we know about pain, can affect how intense it can be on an unconscious level. But again, it's like a lot of things that happen unconsciously, that happen automatically. For example, our breathing rate and our heart rate, we don't set those consciously. That would be way too much to think about in the day if you had to constantly control, how fast your heart was beating. But we know from mindfulness exercises, yoga, deep breathing, meditation, for example, that even though you can't turn these things on and off, you can't decide, okay, I'm not going to breathe, my heart is not going to beat, and thank goodness. But you can influence them when you're aware of them, and that is essentially how pain can work. And education, sorry about that. Education is sort of meant to again bring people into more of a balance of understanding why they're experiencing it, and then reframing it. Because of course, if pain is an alarm and it's based on a feeling like we're under threat somehow, then if we also think actively, I'm under threat. Like this pain means that something is terribly, terribly wrong with me, and I need to do something about this absolutely desperately. It tends to be more intense. So we're going to just talk a bit more about this, so that it makes sense. So pain is created in the brain, is the very important thing. It's not created from nothing. so it's created in the brain from nociception. And nociception, they reviewed it a little bit in the video. So basically, nociception are the threat signals that come from the brain, that come from the body. And in the case of the brain, we know that the actual brain does not have nociceptors, which is why it's possible to have things like awake brain surgery. So I don't know if anybody has seen any of this before, but if you have a moment, go and Google or you go onto YouTube and type in awake brain surgery. It's very, 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 very fascinating. And so that's that. In the nociception from headaches is usually coming actually from the covering of the brain, and it is usually based on, in the case of headaches, it's based on what's called chemical nociception, and chemical nociception is things like inflammation. But the point is, like, there's some start of it, but the brain's pain system has to convert that source of potential danger into actual pain. And just like the video said, our brains are actually constantly getting information that is nociceptive. So constantly getting information about potential threats, because there's always some inflammation being produced in the body. Not all of it is bad. For example, we produce regularly some amount of inflammation in our stomach and our guts, because that amount of inflammation is actually required to help the maintenance process proceed. Like, this is the reason why aspirin and a lot of non-steroidal anti-inflammatories cause ulcers when you take them on the long-term basis, because they're shutting all the inflammation down, even the inflammation, the local inflammation that's actually helping the repair process in the gut. So shutting all inflammation down is also not a good idea. You know, you need everything in its right place and everything in its right amount. So the big thing is that nociception does not equal pain, but it's signals from the body saying, you know, if I've got too much of this going on, or if it's going on in a way that my brain is sort of coded as dangerous, then that can end up, you know, sort of inspiring the brain to create pain. The purpose of pain is to change our behavior, so that we protect ourselves in some way. And usually you get this tipping point where nociception turns into pain when this evidence that we're in danger from all of our different senses is essentially greater than the evidence that we're actually okay. And I can give you another more physical example of this. So, for example, if everybody wants to take their finger and wants to just start bending it back, at some point, you're going to get to a point where you can't really bend it back much further and it hurts. So everybody go ahead and do that. Go ahead and push it back until it hurts. And then, you know, relax it, move your hand again, and the pain goes away. So we got pain. It wasn't excruciating or anything, but we got that pain to stop us from pushing our finger further back. Because if I push it further back from this point, I will tear something. I will tear this amount of this tissue here, and I might hurt the joint, of course, too. So you usually get the pain in the tissues that are being threatened, but we don't have an injury. So the minute that you let that go and, you know, you shake it off, pain goes away. The pain, basically inspired us to not push further, to not push into the point where we're actually going to do some damage, but we didn't actually hurt ourselves. So we didn't need an injury to cause pain. We just got the pain to change our behavior. And there's some really interesting examples of how you can get pain even without injury as well. So there was a case in, I think it was in 1992, and this was in the UK. It was a construction worker. And so this was an example published in the British Medical Journal because it was so interesting. But a construction worker stepped on a nail. So you can see the nail through the boot here. This is an actual picture of that boot. So it went, you know, from the bottom of the sole of the boot right through to the top. And of course, the worker looked down, saw that there was a nail sticking through his boot, felt extreme pain in his foot immediately in the toes, was taken to hospital and was in so much pain that they needed to give him morphine just to get the boot off. And once they got the boot off, they noticed that the nail was between the big and the second toe. It completely missed his foot. And the minute he saw that the nail missed his foot, the pain completely disappeared. And in this case, it was the seeing that there was a nail through my boot is clear evidence from my senses that I have been injured. You know, my foot is in danger. I need to get to the hospital. Vision is a huge, like, plays a big role in providing evidence to your brain that you're, that you're in danger or not. And in this case, the vision was more convincing to the brain than the fact that the foot was not sending signals that there's a nail in my foot. So this can happen, and you're like with headaches. What you're mostly getting, though, is the nociception based on chemicals. So we have all of our nerves are sort of separated into like cables, essentially. You can think of them so that it's like a fiber optic cable. So you have one nerve, and then it's separated into many other smaller parts of that nerve. It's, or more like a bundle of hair would be a good way of thinking about it. So they're all put together, and each hair is sort of specialized in sending up a different type of information. So our nerves will send up information about just how things feel, like touch. They'll send up information about vibration, pressure, so senses like this. And then also they'll send information about these potential threats. And the potential threat can be of basically three different types. So mechanical is movement. So when we bent our finger back, we were giving mechanical threat. And once you get to the point where it's enough mechanical threat that the brain sort of takes notice, then you can get, again, you don't have to, because you can stretch. Like a stretch like this is also going to give me mechanical nociception, because, oh, if I go too far back, I could dislocate my shoulder. However, this personally doesn't actually hurt. This is, but there's going to be people that it does. Depends on the nervous system. It depends on whether that person's brain and spinal cord interpret that stretch as a threat or not. And that's based on a lot of things. That's based on history of injury, genetics, and thoughts about it. Am I worried about stretching, for one reason or the other? Do I know somebody else who's also injured themselves in some similar way? So all of this informs our pain system unconsciously. And then we can notice that we have these certain triggers. So that's an example of that. Would be a mechanical threat. A temperature threat is pretty obvious. So it's too hot or it's too cold. With most people who have chronic pain, they are more likely to experience an increase of pain with cold. And there is a reason for that. So the nervous system can tend to change in persistent pain, where it just lasts, longer than just that short amount of time that most people require when they have an acute illness or an acute injury. The nervous system can change so that it interprets cold as being more dangerous, essentially, than heat. And then chemical. And chemical nociception is what we're dealing with headaches, which makes sense, because in a headache, there's a lot of times there's no physical injury. Headaches that occur as a result of a traumatic brain injury or stroke are a little bit different, but in terms of tension headaches that are related to muscle fatigue and muscle tension and migraine headaches, there's no injury. The person's not getting hit in the head or having anything happen to their brain or their head. Like I said, it's the chemicals are coming from the meninges, which is the layer of tissue that protects the brain, which does have nociceptors, but there's no injury happening. And the interesting thing about the chemicals, there's sort of two broad categories of chemicals that our pain system is trained to react to as being potentially threatening. And one of them is, of course, what we mentioned is inflammation. And of course, nutrition has a lot to do with how inflammation in the body is produced, because we know that, for example, certain types of fats, like everyone's heard of omega-3 and omega-6 fats, a diet that is rich in omega-6 fats, which mostly come from meat, and especially come from factory produced and meat, because the animals they're not given space to run around to have a healthy normal musculature. They have a greater fat percentage in their bodies. We know that type of omega-6 fatty acid is used in the human body to produce more inflammation. So if people have more omega-6s, arachidonic acid specifically in their body, they're more likely to produce inflammation. So more likely to get chemical nociception, more likely to get inflammation-based pain. And the other big one is stress hormones. So stress hormones are also coded for threat, which makes sense if you think about it. If you think about it in a sort of an evolutionary type of way. So if you take away the modern world where things are stressful that actually can't or shouldn't be able to hurt us in the way that traditional threats did, and you think back on the Stone Age, basically. So people would be stressed out when they were like, you would produce adrenaline, you would produce some stress hormones, cortisol, when you were in a life or death, more threatening situation, when you're either getting attacked or having to run away, that's when you'd have these massive productions of stress hormones. So stress is sort of coded for, if I have a massive output of stress hormone, that's happening because my life is being threatened. And modern living has just sort of changed all that. Like now we get stress, when we have deadlines and all these sort of existential things that are threatening us, but they're not actually threatening our lives in the same way. But our brains don't know that. Our basically evolution hasn't caught up to our change in lifestyle. So stress and inflammation as well, because inflammation is the immune system is producing inflammation usually to fight something, a virus, a bacteria, something that's invading the body and threatening to infect it or hurt it in some way. Whereas now we get a lot of inflammation that's actually stress related. So the modern world has changed how our pain systems work quite a bit, and these are our main sources though of this sort of food for the pain system. But again, you can have inflammation and it cannot hurt. You can have injuries to your body that don't hurt. And the difference is that's all sources of nociception, but ultimately the brain and the central nervous system make the unconscious decision to produce pain or not, based on the assumption of whether or not the pain will change your behavior to make you protect yourself. So remember how we talked about, just like I get pain here, so I stop doing this. The pain isn't there to make me suffer needlessly. It has a purpose beyond simply that it's unpleasant. It's unpleasant so that it's highly motivating for us to change our behavior. And basically how nociception gets into the pain system from the body is, so this is an example of course, a hand, but for headaches, you can imagine that the source here will be the meninges. It'll be the covering of the spinal cord in the brain. Something will trigger it. So one of these three types of nociception, either chemical, mechanical, or chemical, mechanical, or temperature. There we go. We'll trigger it. It will send signals, first of all, to the spinal cord. In the case of headaches, it's a little bit different because these signals do not necessarily go straight through the spinal cord. They can go directly into the brain through cranial nerves, but it's the same principle. And but so there's always a gateway in, and at that gateway, there is essentially a baton pass, and the baton pass is going to go then into the central nervous system, which is brain spinal cord region, and then it's going to get sent up into the brain, and then it's going to go and get basically ping-ponged between 9 different parts of the brain that are responsible for making that decision to make pain, and then also making the decision of how much pain to produce. And these parts of the brain are varied. Like I said, there's 9 of them, and only 2 of them are conscious, and the others are completely unconscious, which is why you can't decide to be in pain or not. But the 2 conscious members have a lot of influence. They have a lot of sway. And I sort of like to talk to people to think about it as if this is a committee. So this is a management committee. So information will come in from the body, will come in from the meninges, anywhere where nociception can be sent. It'll get into this committee. And then the committee will have to, again, analyze it. But each committee member analyzes it based on what that committee member does. Your pain system is kind of like a health and safety committee. So most companies don't have a health and safety committee where that's the only thing that these people work on. Most people have, you have your company, which is your body, you have your workers, and then some of these workers also sit on the health and the safety committee. And what they do in their normal work hours really influences what they think about the nociception coming in. So like some of the parts of the brain that are part of this are responsible for our stress responses. So, or responsible for our emotional regulation in general. And so we know that when people have, for example, a history of anxiety and depression, that kind of tells you that the emotional regulation systems of that person's nervous system are essentially sensitive to threat. They're sensitive to responding, highly emotionally to threat, and people with a history of anxiety and depression are therefore more likely, in fact, to produce physical pain. And there are other parts of the brain that are responsible for like movement, orientation, automatic movements and such. So they will tend to, you have more involvement in the processing of these when there's like a strong physical component to the pain, a strong movement component, like a limp, for example, something automatic that the body does. But at this level as well, the spine and the sort of entry point can also increase these signals, because when this baton gets passed, the central nervous system is plastic. So it can actually multiply it. So you can think of it basically as an amplifier. So when you plug a guitar into an amp, you can strum the keys faster or harder, but there's a limit to how much sound you can get out of that guitar. When you plug it into an amplifier, though, you just turn the dial up, and even if I'm not playing the guitar any harder or with any more vigor, if I turn the volume up at the amplifier level, it'll get louder. And essentially that's what the spinal cord can do, is it can be the amplifier. So it can take whatever signals are coming in, and it can turn them way, way, way up. It can multiply them, in which case the brain gets a whole lot of noise and is more likely to produce more pain, or it can turn them down. So that's a function of sort of step one of how is this nociception getting in. And then we also have this phenomenon where we're dialing everything up is known as central sensitization. And this can happen, so I'll just quickly actually go back. So this can happen at the spinal cord root, but it can also happen at each of these entry points. And like I said, we'll talk more about, like in the course, we go into great detail about what all of the different areas of the brain that produce pain do, and how they're influenced. But you've got at least 9 connection points, and you can think that at each of them, you have the potential to amplify, because the brain can do that. The brain can change. The brain can learn. Unfortunately, it can learn pain, but it can also unlearn it. So that's the great thing, is that all of our experiences, including pain, are actually learning processes. And the process of learning can change. So it can change how this system interprets things, and therefore how much pain people are sort of prone to experiencing. And with central sensitization, which is essentially the process of learning pain, there is this amplification at the spinal cord, at the cranial nerve root, where and in the brain, where the connection points are happening, where these 9 sort of parts of the brain come together to interpret pain. There's a chemical change that happens there. So you do get more central nervous system inflammation. So inflammation also drives this. And normally what's happening is that, like you said, we've got a signal comes in, there's a kind of a baton pass, it kind of goes in, and then it's going to be, sent to the next nerve in order to get into the pain processing center. With central sensitization, we add more doors, so that basically you have one baton comes in, and then that baton gets like multiplied into 100 batons instead of just being passed on as a single one. So I know this is a complicated picture, but it just sort of gives you the idea that there's just more going on. There's a lot more inflammation being produced, and there's a lot more reactivity. So one signal can become many more, and of course that the more food for pain that the pain system gets, the more likely it is to, to eat it. It's like going to a buffet. If there's more food available, you're more likely to stuff yourself. And essentially the pain system stuffs itself a little bit on excess nociception that's amplified through this process. So how do we assess central syndromes? And migraine pain is a central syndrome. Well, there's a couple of ways. Now, there's some ways that are specific to migraine, but there's also just ways that are specific to pain in general. So we want to know, okay, is this pain being driven mostly by the sensitization process in the nervous system, where things that are coming in are being amplified, or is it sort of more reflective of something you would expect from you've torn a ligament, for example. It's inflamed, it's going through the healing process, and the pain is sort of fair, for lack of a better term. It's a little bit more driven by the healing processes that are happening in the body than driven by these changes in the nervous system. Well, there's a couple of ways that you can determine that. And one is to do an assessment of, does a person have other symptoms that are consistent with this central sensitization? Another way is, of course, just the amount of time a person has had this. When we talk about migraines, they're pretty well in the, just generally speaking, they are chronic. So they've been going on for a period of time. The definition of chronic or persistent is sort of what we like to say more. Persistent because they can come and go. It doesn't necessarily have to be consistent, but they go on for a longer period of time. And the definition is more than 3 months. So in order for somebody to sort of qualify as having persistent pain, that's not necessarily equal to an acute healing process, it has to be present for at least 3 months. And persistent pain also tends to be more painful, which is consistent with, again, the nervous system is learning how to produce pain better. It's learning how to amplify it. And because this process happens in the central nervous system, your central nervous system is responsible for everything that happens in your body. So when people are centrally sensitized, it doesn't affect just the part that they're most aware of. So we're always most aware of where we feel the pain, but it affects your whole nervous system's functioning. So all of your body systems are controlled by your nervous system and your brain. So people will notice that they also, when asked, when really like, okay, does this also apply to me? They'll notice that they do have other symptoms. So a couple of them are things like feeling tired and unrefreshed when waking from sleep. My muscles feel stiff and achy, just overall, whether I've done an exceptional amount of work that I don't normally do or not. Anxiety attacks, again, grinding or clenching the teeth. A really, really common is, of course, problems with the digestive system, because the digestive system is linked directly to the brain through the vagus nerve. And what happens in our digestive system influences us a lot. Needing sensitivity to bright lights, for example, having headaches, burning when urinating. So in any case, people will, this here is an assessment of central sensitization, and if you get a certain score, it's indicative of having a high enough score that we would say, okay, it's likely that this process, this change to the central nervous system, is amplifying, like it's responsible for the pain. So anything below 29 is normal. So most people will have some degree of these symptoms. Mild means that there's some degree of these changes to the nervous system is amplifying and driving the headache pain or just pain in other areas of the body. Moderate, severe, and extreme. We don't know how much the score needs to change in order to say that that basically there's been a significant improvement that a person will notice, but we do know that if it goes, for example, from severe to moderate, or from moderate to mild, or from severe to mild or subclinical, then that means that the person's pain will also go down. And we know from headaches, it's not well established exactly how much this needs to change, but we know from studies on other types of persistent pain that people, as long as the score stays high, quality of life is lower than when people are able to bring the score down. Like this, when the score changes, that sort of tells you that changes are happening to the nervous system that should make this better. Okay, so that's the background on pain in general and how this how pain works. So now let's talk a little bit about chronic migraine and headaches, because of course they are a central sensitization, there's a central sensitivity syndrome, and overall, up to 4% of the world's population has chronic migraine headaches. Up to 50% of the world's population has experienced a migraine. So migraines, again, are not completely uncommon. If a person has them 1 or 2 times, then that's normal. That's part of the human experience. When they're problematic is, of course, when they're consistent and they're resistant to treatment, and of course, when they really interfere with people's enjoyment of life and their ability to, just live their life and do what they need to do. For some general risk factors, age is always a risk factor. Migraine headaches tend to peak in younger people, actually, and the older people get, the less likely it is that when they have a headache, that it's a typical migraine headache. Poverty makes people more likely to have headaches, and this is due to stress. And actually, poverty makes all types of pain more likely because poverty is threatening. And that's a very simplistic answer. It's more complex, and definitely a psychologist who study stress would be the better people to ask about this. But we know from studies that having low education, low income makes you more likely to have headaches, because essentially you are more at risk in life for not being able to deal with things, especially with inflation, the cost of homes. I'm sure everybody can relate can relate to this. Other central pain conditions, or other, again, we mentioned a little bit, other mental health conditions that can affect how the parts of the brain that make the pain respond to potential threats. So PTSD is a big one, depression, bipolar disorder, childhood trauma, panic disorder, multiple sclerosis. So that involves some damage to the brain, and any damage to the brain can also change how it interprets these signals that come in, whether it interprets them as dangerous or not. Insomnia increases central brain inflammation. Stroke, of course. Sorry, I have MS there twice. Asthma, Raynaud's. So allergic reactions, rhinitis, and lupus. Obesity. The more excess weight we carry, the more inflammation that we can potentially create because of stored fat and stored fat's relationship to inflammation. A history of episodic migraines. So people who have had not consistent migraines in the past, you're more likely to have that progress to they come on all the time. Women are much more likely to have migraines. There is a component that's related to estrogen. Actually, estrogen makes the nervous system more likely to sensitize. Overtreatment is actually a big one. So people who use a lot of medication to manage headaches when they do appear are more likely to progress to chronic headaches. And some of that could have to do with just the overtreatment itself, and the overtreatment making the problem more threatening than it necessarily would otherwise be. But this is also a big question mark. We don't know exactly why that is, but we know that it is an issue. Genetics. Most people with chronic migraines have a relative. So first degree is mother, father, who also have migraines, and of course caffeine intake. You are allowed to get some caffeine, but more than 100 grams a day on a regular basis, and definitely more than 400. So there's kind of these two levels. For people who are caffeine sensitive, more than 100 milligrams will do it. And for people who are caffeine resistant, but drink a lot of caffeine, more than 400 is linked to it in increased risk of headaches. Okay, so how do migraine headaches look? So you usually get these intense pain behind one eye. So it's usually not both sides at the same time, but of course it can be, but it's very, very commonly just behind one eye. It's preceded by aura in quite a few people, which is just this almost stroke-like symptoms for a lot of people. They get vision loss. You can see wavy lines. You can get sort of blinded to light. It can travel to the face and the neck. So oftentimes it'll kind of go over to one side and then come over. It's usually worse with exercise. So people will notice if they have headache and they try to, for example, go for a jog, get out, walk, climb up and down stairs, anything that increases blood flow, that makes it worse. Sensitive to light and sound, nausea. A lot of people do vomit with migraine headaches, sweating, and again, these abdominal symptoms, because our brain and our guts are intimately connected, and they can last up to 5 days at a time, but that's a very person specific. Just out of curiosity, I'm not sure how many people who are taking part in this have migraine headaches, but go right ahead and jump in if you do, and share some of your experience. But this is very common. And after a headache, because there's quite a cascade of things happening. Like when our brains are producing pain, the brain is very active when it's producing pain. It basically takes a lot of mental resources to do this, and so your neurons are literally firing more and at a higher intensity, for lack of a better term, but they're firing more intensely and in more rapid succession. So it's work. And after headaches, people are often really tired, like quite fatigued, and that can last for a while. You can be completely incapable of thinking. You have that typical brain fog, because essentially, the brain has just gone through a marathon, and then it goes into a bit of a refractory phase and tries to sort of recoup. But this doesn't mean that the brain is necessarily damaged, but it's been exhausted by the process of making the migraine and going through the migraine. Oh, I do see that we have a couple of comments here. So yeah, it happens to me roughly once a year. Absolutely. And prone to it. Sometimes it's throbbing for 3 days. Yeah. So this is all very, very common. Me too. I usually have it for exactly 48 hours with nausea and vomiting. And this 48 to 72 hours is really common too, just because there's something known as a wind-up phase, which is basically how the brain becomes more excited about something. So like when your brain is really focused on something, or you're feeling really what's the right word, stimulated. There we go. The brain goes through a wind-up phase so that it essentially can do more work. And unfortunately, in a migraine, the work that it's doing is producing the migraine. But that process of extra activity has a limit. Like, it actually does have a physiological limit, and it's usually between 48 to 72 hours, and then the nervous system can't keep the activity up anymore. So again, it gets acutely tired, and then it has to go into a rest phase. So most people find that their headaches last about that long. Now, in terms of how these are medically managed, there are a bunch of different medications. Antihistamines are used when people get headaches as a result of an allergic type reaction, because again, you're getting more inflammation production. Triptans, similarly. 5 serotonin antagonists. Serotonin is part of this wind-up phenomenon where the brain gets super excited, in this case about producing pain, but a lot of medications work by blocking that. Caffeine, interestingly enough, even though it's a risk factor for migraines, for getting them, once you have them, certain doses of caffeine can actually help manage them. Botox is actually used for some people who have a significant muscular tension component. So when we look at lifestyle management, we're looking at, first of all, avoiding caffeine. Avoiding the overuse of medication is actually quite good. So actually, normally people should try not to immediately go to multiple medications. Somebody had a Botox. Oh, haven't they had Botox for mining? Yeah. So weird. Could not feel my head. yeah, absolutely. We're still not entirely sure why it is that Botox works, but there is a connection between, of course, muscular tension and the production of inflammatory particles, for example, or particles that are nociceptive, so that send these warning signals in that can then be interpreted as danger and produce pain, by a nervous system that's sensitive to them. Correcting vision, again, because eye strain is part of that as well. Any element of strain can sort of produce this threat effect pain. Avoidance of alcohol and smoking, these are associated with cluster headaches, and biofeedback therapy. So biofeedback therapy is especially good for people who have a very strong, like everyone has a strong physiological response to pain. And oh, sorry. So somebody's asked, can you explain why caffeine can relieve it? Caffeine can temporarily produce a couple of effects. So caffeine does increase central nervous system blood flow. Sometimes that can clear out some of the excess nociceptive chemicals by just simply thinning them out, because if you've got more blood flow, you have less of them relative to, and that can sometimes just bring it below the sort of the threshold level, because there's always a threshold level. Like our brains and our bodies can tolerate an amount of everything pretty much, and it's only once you get into that non-tolerable level that you start to get symptoms, and that is one of the possible reasons. And also caffeine as a central nervous stimulant produces the antidote to being. So whenever you're stimulated, your body immediately starts to produce sort of the antidote to being stimulated. So for example, like when you produce extra, like adrenaline, one of the things that adrenaline also does, adrenaline and cortisol, is that they actually are in the short term anti-inflammatory. So whenever you have a stimulant that gets in and produces a sympathetic nervous reaction, that actually starts the process of trying to get the nervous system out of that reaction and to calm it down again. And I know that sounds a little bit funny, but it's the same with like when you get injured, that's when the healing process starts. So I hope that makes a little bit sense, but that's why caffeine can potentially relieve it. And then you also can assess headaches by looking at, there is something called a migraine disability assessment. And you want to make sure that the person doesn't have any red flags that, so does that have anything to do with vessel dilation? That's actually, that I am not entirely sure about. That is, I will have to look into that. I am not entirely sure what that has to do with vessel dilation. It has to do with vessel dilation in the sense that you get more blood flow, and blood flow dilutes the concentration of stress hormone and other nociceptive chemicals in the blood, so that if there's less in the blood, it can't send as many signals at the same time in the same quantity, so that you get the same sort of excess response. But specifically, whether vessel dilation itself has anything to do with it, I am actually not sure, but thank you for the question. That's a good one. Just another sort of note about red flags is there are some red flags are medical emergencies, or that can also cause headaches that are not just related to central sensitization. And so things like acute glaucoma, a stroke. Now I've talked to stroke patients about this, and sorry, it's spelled wrong. That should be stroke. A stroke headache, they say, is unlike any other headache you've ever had. So it doesn't feel like any type of migraine headache that a person's had. Of course, you're more likely to have that later in life as well, when actually your risk for migraine headaches goes down. A mass in the brain, so a brain cancer, for example, tends to just possibly feel different. Stroke, definitely. Brain tumors don't necessarily feel different than a migraine, but then of course there would be normally other symptoms. Infections. So does the person have any other signs of infection? So your typical swelling, paleness, the other symptoms, coughing, all over body pain. So anything like that, and cardiovascular causes. So heart disease can cause migraines. Then again, though, you would expect to see that the person also has some high blood pressure, for example, obvious signs of cardiovascular disease. And then you can also do an assessment for trigger points, because there are a couple of muscles that if they get very, very tight, and they form trigger points that they will refer pain into the same areas that people can experience a migraine. And the most common ones are actually your upper traps and this muscle here, the sternocleidomastoid. And of the occiput can do it as well. So these are the muscles right at the back of the head. And these are also the muscles that tend to get more toned. They tend to get tighter when people are stressed out. So like another physical response to stress is increased muscle tension, because again, your body, when it's stressed, when it feels like it's under threat, it goes into protective mode. And part of our protective mode is tighten everything up, get ready to fight or flight. And if that's constant, then you get this constant low-grade muscle tension that can then refer into the head in specific muscles. So those are some of the things. And another big one, another assessment is the pain catastrophizing scale. When people, and catastrophizing is part of our conscious response to pain. And it's one of the few conscious things that we can do that has a significant effect on how intense pain is. So it's a set of questions that people again rate. So do I agree with, do I think this? Not at all, to a slight degree, to a moderate degree, to a great degree, all the time. And they would rate, they would rate these various statements. Like, I worry all the time about whether the pain will end. If I think that all the time, that's a 4. More than 30, a score indicates significant catastrophizing. And catastrophizing is part of the process that drives the brain to actually learn how to get better at making pain. So it's all statements that basically indicate that we can't deal with the pain and that it's extremely dangerous. That can drive it up. And there are strategies for reducing catastrophizing. So mindfulness based strategies, psychological strategies. So we recommend that if anybody has significant migraine pain, it is helpful to sort of examine your thoughts about migraine pain. Like, are conscious thoughts amplifying it? And again, you can't decide whether to have it or not based on what you think, but they can increase the frequency and the intensity. So it's worth going through this and actually doing the score. And if you notice that you do actually have a high degree of catastrophizing, then to look into some of the tools for reducing that, because that is part of it. That's part of the treatment. So now let's look about what else can we do? So there are diets that can actually help with migraines, and a lot of them are looking at modifying the production of inflammation. Oh, sorry, I do have, can you explain how estrogen dipping too low at the end of the luteal phase can have an impact on migraines at that time? And also, how can you try to reduce it when it happens if low estrogen is the trigger? So the thing is, low estrogen, changes in estrogen can't flat out cause migraines in themselves. Women are more sensitive to chronic pain in general because of the effect of estrogen on nociception and on neuroplasticity in pain. But actually, the exact relationship between there are things known, like estrogen has a number of different effects in the brain. It sensitizes numerous different areas to the impact of nociception, but how you can, for example, exactly control estrogen levels to influence migraines is not well established, because there are people again who have changing estrogen levels at the luteal phase, and they don't have migraines. So the intensity of the pain doesn't necessarily, and the ability to modify migraines doesn't necessarily depend on controlling estrogen levels. But some of the things that we'll talk about will definitely they touch on this a tiny little bit. Some of the ways actually that the low fat diets and like ketogenic is it modifies fat storage in the body. Fat has an impact on estrogen levels. So there's a bunch of different relationships there. But yeah, that's a good question. But it's not, you don't need to be able to control this necessarily. And like controlling estrogen levels is a bigger topic than just what we're addressing here. But thank you for the question, but we will talk about that more in the actual course. So low fat diets, low fat vegan, decrease overall, like, nociceptive potential from chemicals. Ketogenic diet as well. The ketogenic diet actually is fairly well researched for headaches. So 90% responder rate for within 1 month. Eliminated headaches for 7 months in one case. So the trials are all really slow, slow, not slow, but small. But they're really inspiring. Modified Atkins. So again, you're looking at modifying blood sugar balance, which also has an impact on estrogen levels. We'll talk about this. Estrogen is highly impacted by diet and also by the composition of the bowel flora. So a lot of things that influence bowel flora composition, which is carb management, which types of carbs people are eating, and that explains some of the effects here. But a low glycemic index diet also helps quite a bit and takes about 1 to 3 months. And it's working also again by decreasing some of your inflammatory production. So focusing on the decreasing the nociception that's feeding it. And then there are supplements for headache as well that have been researched to help quite a bit. And a lot of these work on trying to modify energy management in the central nervous system. Vitamin B2, very, very, very safe, very affordable. 400 milligrams a day decreases the frequency and severity by about 35%. So definitely worth trying. Coenzyme Q10 as well, so 300 milligrams a day. Magnesium is also known to, it reduces C-reactive protein, which is like a measure of systemic inflammation. Multi-probiotic species, our bowel flora are huge in basically sensitizing our nervous systems to nociception, and activating the vagus nerve, like getting the nervous system to go into relax mode instead of fight or flight mode. That's a function of our probiotics and our bacterial microbiome as well. And butterbur. Butterbur is this herb here. It's not widely available, but it is available in from some brands, and 75 milligrams for 4 months helps with allergy-related migraines by modifying this histamine response to allergies. But also these are the ones that again have generally the best response to them. Okay, and other helpful therapies are anything that, again, works a little bit more. And so we're talking about now the input to the nervous system that causes pain. The output is, of course, how does your brain then interpret that? And what are some things that influence how it interprets that? And the short answer is stress management. So any therapies that help with stress management, that help with the mind-body connection, also help with headaches. We have a need for aerobic exercise the same way that we have a need for other types of nutrition. We need at least 150 minutes a week in at least 10-minute increments. If you don't get that amount, your nervous system doesn't function properly. People are more likely to be depressed simply because of lack of exercise. So think of exercise as a vitamin. It helps the immune system function properly too. And the immune system and the nervous system are intimately connected. They share neurotransmitters essentially. Like neurotransmitters are how our brains, our neurons communicate with each other, but they also can be essentially interpreted and reacted upon by our immune system. And so they're not really separate systems. They work completely in tandem with another. Qigong is a breath exercise, a mind-body exercise, also very physical. Massage and progressive muscle relaxation. You need to do it for at least 5 weeks to see the results. But again, the research is there. cognitive behavioral therapy. So that's changing our mind about pain. So that's essentially challenging some of these catastrophic thinking ideas that we know can intensify pain from any source, but especially with headaches as well. And then self-management. So just learning how to manage with even when a person has headache pain, like how to sort of like what do you need to get through it, and how can you function even if you have headaches still. So these are also extremely useful. So sorry, that hour went by super fast, which always tends to be the case. I am open now for some questions. Does anybody have anything else that they wanted to ask?
Just before we get to the questions, I just want to, I know we've got a couple, but I just want to thank everybody for coming, and thank you, Vanessa, as well, for doing this webinar. It was amazing and very informative, and I'm sure that everybody here learned a lot. Just as a reminder, as we said, this is kind of inspired in a preview of Vanessa's Nutritional Therapy and Chronic Pain continuing education course, which begins at the end of the month, so May 28th. It's 4 sessions long. If you are interested in the course, you can reach out to us at any campus at IHN, and we'll help you out. But yes, now we will do some questions. So, Vanessa, I don't know if you can see the Q&A section, but we've got a section from, question from Sabine saying, can you explain how estrogen dipping too low at the end of your luteal phase, start of your menstrual phase, can have an impact on migraines at that time, and how can you try to reduce it when it happens?
Oh yeah, so I did actually answer this one at the like in the middle. I had a shot at it, so sort of the point with this one is that like when estrogen dips too low, for example, there are a lot of potential reasons for that. Some of them actually have to do with bowel flora, which again, it's kind of a long answer, but at the same time, you don't need to control this in order to change migraine status, because migraines are not just simply caused by estrogen dipping too low, so I kind of encourage people not to get too focused on this one particular aspect of it, but to look at it more holistically, and to like with estrogen rebalancing, we always involve the bowel flora in that anyway, for example. So that would be that's it's a bit of a larger topic, but you don't have to change estrogen levels in order to change the intensity of a migraine. Like you can use some of the other sort of tools that we've already discussed in order to look at it, but that is something that we go into more detail in the course. Yeah.
Amazing. Then we have a follow-up from Sabine as well, saying any other recommendations for acute migraines, especially with nausea and vomiting?
So with nausea and vomiting, and the thing with it, because a migraine is by definition not acute. So I know that this is an interesting way of saying it, but by definition, if people have persistent migraines, so you've had more than one of them for more than 3 months, which is pretty well always the case, then you have to think about it as basically a chronic pain condition, and chronic pain conditions do require at least usually 12 weeks of therapy before you can really say, okay, this is getting better. The nausea and vomiting, honestly, the best way to deal with it is to try to calm the nervous system down, because the nausea and vomiting are part of the wind-up response. They're part of the nervous system essentially getting extremely reactive to the threat that is essentially building. And when we notice, like, okay, I am going to have a migraine. I'm going to be completely useless. I'm going to be, I need to get out of, I need to get out of this situation. I need to get into a dark room. I can't be around other people. I'm going to be disabled for the next 2-3 days. Like, these are things that we all think about when we have migraines. And actually, trying to like recognize and accept the process actually decreases the intensity of that. So very, very, very acutely, ginger helps with nausea and vomiting. Some basic things like vitamin B6 actually helps with nausea and vomiting, and ginger. Very acutely, just based on personal experience, I found a ginger kombucha can help decrease it a little bit. But also very importantly is how are you thinking about it? Because the thinking process has an impact on how intense it's going to be. So think about it more as a slightly more global process. But within like we said, for most chronic pain conditions, and migraines included, 12 weeks is sort of needed of doing a system of therapy. But also you will be able to, like, you'll see a little bit sooner that things start to change, that things get a little bit like easier to deal with. So I hope that answered that question.
Amazing. Now we have a question from Heather Mills. How does barometric pressure affect migraines?
Yeah. So barometric pressure, now this is one where I am not actually 100% sure about the answer, but I can theorize a little tiny bit about it, is barometric pressure can be nociceptive in people who are sensitive to it, because remember, nociception is essentially signals of potential threat. And barometric pressure is partially regulated by the hypothalamus. Hypothalamus is one of the parts of the brain that is part of making pain. And when the hypothalamus is threat reactive, so very sensitive to threat, it can perceive changes in barometric pressure as threatening, and can produce pain as a result. Barometric pressure is, of course, not actually threatening, like it can't, not in the amounts that we normally experience it, but it's not actually just with migraines. Barometric pressure can affect pain in people who have like a, shoulder pain, for example, can be affected in people who are highly centrally sensitized by changes in barometric pressure. So the big thing about that is that we can't control barometric pressure. We just want to focus on overall, how do we manage the migraines? How do we manage the chronic pain from migraines in a more holistic idea, in a more holistic sense? So I hope that answers the question.
Wonderful. Yeah, that was a great answer. We have another question from Robin Stevens. They mentioned that they've been tracking possible triggers for a few years, and it's frustrating because there's so many different factors, but they've noticed triggers from all different kinds of things, whether diet, stress, hormones, chemical sensitivities, and they're kind of limiting things regularly, but now they're quite restricted. So I want to know if you have any kind of thoughts about that kind of process.
Yeah. When it comes to chronic pain in general, you don't want to get into the cycle of essentially trying, and this is with most chronic health conditions, but definitely with headaches especially, but food sensitivities as well, is actually we want to try to get away from the cycle of constantly eliminating things, because that just increases stress in the long term. That makes your world smaller. It puts a lot more pressure on you to manage things that are actually not necessarily within your control. So chemical exposure, for example. And we know that chemical sensitivities as well, especially, and sensitivities to weather, for example, these are signs of a centrally sensitized nervous system. The centrally sensitized nervous system doesn't necessarily need all of these things to be eliminated. It needs to learn basically it needs to relearn how it's responding to these triggers, and that is a different process than trying to eliminate all of them. So those are my thoughts about it. Generally speaking, the more people try to control chronic pain, the more it tends to end up controlling you. So when you're in the cycle of constantly eliminating things and trying to control possible exposures, you're in the cycle of trying to basically it'll manage the pain from a very like from an external point of view, where you don't have a lot of power. So actually it requires it just requires a different approach. So especially same thing with stress. We can't eliminate stress, but we can manage it differently. So that's why I really recommend the more holistic approach. Don't focus on every little thing that could potentially be a trigger. Focus on how do I manage my pain when it does happen, when I have a migraine, and how how can I like apply some of the principles here. How can I you can use obviously use the dietary challenges. Try for example a keto. See how that works, but the end effect is that you're not trying to this is going to sound sort of weird and philosophical, but you cannot beat your pain system. You can't beat it down because it's there to save your life. Like it's evolved to save us from potential things that could potentially kill us, and it is stronger than we are. It is mostly unconscious, so we can't kind of just like try to never have pain or try to never be exposed to these things. What we want to try to focus more on is how do I manage, what I'm experiencing, and part of that is with some of the therapies that we mentioned, but part of that is also a bit of a Zen approach. It's learning to accept and to think differently about how you're trying to control the migraines. It's one of those things where it tends to be the more you try to control it, the bigger it gets. So we want to kind of try to have a different relationship with the migraines, and that different relationship actually tends to make them go away on their own. So that this is again it's a bigger topic, but I hope I've kind of given you a little bit more information on that.
Fantastic. Yeah, that was a great, that sentence, the more you try to control chronic pain, the more it controls you. So we got another question here from Sabine asking if you could expand on the 48 to 72 hour time frame, and that you mentioned a wind-up phase. And they say that they can set their clock to 48 hours exactly, and their headache and migraine is gone.
So wind up basically refers to the activity in what are called NMDA receptors, and these are the receptors that basically turn the nervous system on so that it is like more productive or more active, and these receptors. So you can think of them as like they're like doors that open for a while, and then after a while it's like they're on a timer, and then they automatically have to shut, because if they stay overactive, the brain will get damaged. They'll actually burn the nerve out or burn the neuron out a bit, and so that's what this wind up phenomenon is, and it tends to like start over the course of 1 to 3 hours, where there's a stimulus, the nervous system responds, and then it gets like, oh, I need to pay more attention to that. I need to focus in on this. I need to like get really active and try to solve this problem or solve this whatever it is that I'm working on. So in this case, it's whatever potential triggers of the migraine are, and then it sort of goes off on its own little journey. It gets super revved up, and again stays at this high RPM. It would be like driving a car too fast, like getting in the really really high RPMs, and then you're like, okay, the motor is going to burn out, and then you need to bring it back down again. So that's what the wind-up phenomenon is. And the nervous system it has this like fail safe, so that it kind of shuts that process down by again automatically closing these doors, so that the receptors can't continue to be active for more than this time frame without going into a rest phase. So that's what it is. And a lot of people will notice this, that they just. It's the same thing with certain emotional states, because again, this is all also produced by our brains. Like a lot of the time, you just cannot be extremely happy or extremely sad or extremely upset for more than 3 days. Like at some point you just kind of realize like, oh, I'm not as high anymore as I was. Like there's a bit of a natural roller coaster to a lot of what we experience because of this phenomenon that our brains can actively, like very overly actively work on anything for too intensely before this refractory phase sets in. So I hope that answers your question.
Thank you. And we have another one from Robin. saying they totally get what you're saying about not letting food control you, but I've wondered if maybe the migraine is the body's way of telling them that a particular food is damaging them, and so they shouldn't eat it.
That's a difficult question to answer. The answer is it can possibly mean that, but it can also be learned behavior, like as in the sense that our nervous system also learns pain in the sense that it learns to automatically respond to certain things, regardless of whether or not that thing means what it used to at the time. And I'm just trying to think of a good example that will make this make sense. Okay, well, here's an example. Here's a very physical one. Okay, but let's say I tore my shoulder playing baseball at some point. Like, let's say I just went to throw the ball and I tore it here. Then there's an acute inflammatory response, healing starts, the thing heals. But let's say that even after the thing heals and I've gone into an MRI and it shows, yeah, everything is healed, that every time I go to throw a ball, it hurts. So then it's like, okay, well, why does it hurt? Let's say every time I feel pain, then I go and I make sure, okay, I don't have a new injury. I go into an MRI. Nope. Every time it's healed. But every time I do this, it hurts. What has happened there is basically my nervous system has programmed that when I do this, because that hurt me once, now every time I do that, it's going to activate that pain program, even if the injury is completely healed. And that can happen with other things as well. So again, where you get this program, this protective program starts, so that every time a trigger is experienced, even if the consequence is not there anymore, it happens anyway. Phantom limb pain is the exact same thing. Like, you don't even have an arm anymore, and your fingers hurt, because there is a program in the brain that actually connects the fingers in the brain to like whatever original injury, produced the whatever caused them to lose their arm, and that program stays, because the nervous system can basically hold on to changes, even though the body is not, whatever happened in the body once is not happening that way anymore. And that again is because the nervous system is made of different material than all of your other body systems. All of your other body systems, all your other cells, you get new ones eventually. Like all your skin cells, you get totally new skin cells like every 2 years or so. They're not necessarily better than the old. We still age, so the new skin cells are not necessarily as good as the old ones, but they're different, they're new, they're not you don't have the same skin that you had when you were a baby. You do have the same nerves that you had when you were a baby. You do not get new nerve tissue, you don't get new neurons. They age with you, and because of that, there's this interesting discrepancy of like what the brain can do and what the brain remembers and how it gets programmed compared to like how the rest of your body sort of functions. And so what I'm saying is it is possible that is the case if that food has a really negative effect on your immune system, or has a negative effect on your bowel flora, which we talk about a lot in the course, how that's related to the programming of the nervous system for pain. But it doesn't have to be. It could be that there's a learned program there somehow that is sort of now controlling things, even though your body is actually not being damaged or not responding in the way that it may have at some point. We know also that just fear itself produces pain, because fear can trigger a threat response. And that's the whole point, is pain is a threat response. It's meant to change your behavior to protect you. But oftentimes the pain doesn't protect you at that point. It's because it's not because it's the situation is different. It's not functioning the way that it was sort of intended to. And the point of chronic pain therapy is to try to retrain that system again, so that it's being more functional.
Fantastic. Well, we have a lot of thank yous in the chat. Thank you very much. Thank you. Excellent presentation. Thank you. Powerful presentation. Thank you very much.
Okay, thank you so much, everybody. No, it's great to have a chance to present, and I hope I'll see some of you guys later then.
Yes, thank you everyone for attending. Thank you, Vanessa, for such an insightful presentation. And I feel like the Q&A section helped a lot of people as well. And it was a pleasure having you all today. Thank you very much.
Absolutely. Thank you. Okay, take care, everybody.